NAPLEX video number 3, hypertension. So what is hypertension? It is an elevated arterial blood pressure. And hypertension is the product of cardiac output and peripheral vascular resistance. Yes. So what causes these disturbances in blood pressure? So it's usually a neurohormonal system, so like RAS, renin, angiotensin aldosterone system, or the sympathetic nervous system with the beta receptors, or it could be with just sodium, calcium, and natriuretic processes. There's two different types of hypertension. There's essential, which means it's unknown, you just have high blood pressure, or secondary, so it's a cause of it. So like you're on NSAIDs, increased blood pressure, so you have high blood pressure because you're taking a shit ton of ibuprofen. Diagnosis, it's 2 or 3 elevated blood pressures in 2 or 3 different settings. Now I'm going to go over the classifications and the recommendations based on the classifications. So normal blood pressure, less than 120 over less than 80. No recommendations, you're doing great, keep it up. Elevated blood pressure, 120 to 129, less than 80. Lifestyle modifications. Stage 1, hypertension, 130 to 129 over 89 or 80 to 89. Meds or lifestyle modifications depending on the ASCVD risk score. If it's greater than 10%, then you need meds. If it's less, then you need lifestyle modifications. Stage 4 is greater than 140 over greater than 90, and you need meds and lifestyle modifications. Non-pharm treatments, we got diet, exercise, limiting alcohol intake. The goal if you have high blood pressure is to get a blood pressure less than 130 over 80. Some little tidbits, if you're white, you can start with a thiazide, calcium channel blocker, ACE, or an ARB. If you're black, it's recommended thiazide or a calcium channel blocker, CKD, ACE inhibitor, or an ARB. So ACEs and ARBs are usually the main go-to for first choice unless you're African American. So now we're going to go through all the drugs, and it's going to get super boring, and I don't know how to make this fun, so I'm going to do my best. So thiazides, we're going to go over the mechanism of action, side effects, contraindications, and other good things. So thiazides are great for the elderly and African Americans because their blood pressure issues tend to be from volume problems, fluid volume, or from peripheral vascular resistance. So thiazides are great for the old people and black people. Also, it's less effective in renal insufficiency, so the closer you get to creatinine clearance at 30, you might want to switch to a loop. So, mechanism of action of thiazides, increased secretion of sodium, chloride, and water from inhibiting sodium chloride ion exchange. It decreases extracellular fluid volume, which decreases peripheral vascular resistance. Side effects: glucose disturbances. Lipid effects, so negative lipid effects. You might have high hyperlipidemia, hypokalemia, magnesemia, chloridemia, and bicarbemia. That's not a word, but low bicarb, magnesium, chloride, and potassium. Hypercalcium and uricemia. And contraindications are anuria. Now let's go to loop diuretics. Loop. It's on the loop of Henle. So, mechanism of action, it inhibits the reabsorption of sodium and chloride by interfering with the chloride binding of the sodium-potassium chloride system. Renal vasodilation occurs, which decreases renal vascular resistance, decreasing peripheral vascular resistance, which decreases left ventricular filling pressure. Lots of decreases, fun stuff. Excuse me. Side effects, another glucose disturbances. You'll see this with the diuretics. Increases in cholesterol and triglycerides. Now we've got the electrolyte disturbances: hyponatremia, kalemia, chloridemia, calcemia, magnesemia, and bicarb. Hyperuricemia. Contraindications: anuria. If you're not peeing, don't use it. Now we've got potassium-sparing diuretics. Mechanism of action: inhibits sodium-potassium ion exchange, blocks passive secretion of potassium. So side effect: hyperkalemia. You're not secreting it. Hyponatremia, bicarb calcium, and chloridemia. It's important to note that hypomagnesemia occurs in triampturine, whereas hypermagnesemia occurs with amiloride. Also has negative effects on lipids. So last diuretic, really, we can go with aldosterone. They're not really a diuretic, but aldosterone antagonists. It inhibits the effects of aldosterone on renal tubules, enhances the excretion of sodium chloride and water. Side effects: electrolyte abnormalities, and then spironolactone can cause gynecomastia in men. Contraindications: hyperkalemia, renal failure, and anuria. So now we're going to move on to non-diuretics. So let's go with beta blockers. Mechanism of action: reduces heart rate, cardiac output, and blood pressure. It reduces the sympathetic outflow of CNS and brain release. Side effects: exercise intolerance, fatigue, bradycardia, depression, cold extremities, sexual dysfunction, exacerbation of peripheral vascular diseases and airway diseases, glucose disturbances, and decrease in high HDL and increase in triglycerides. Contraindications: AV block, whatever that is, cardiogenic shock, heart failure, acute compensated heart failure kind of thing, heart failure, and hypotension. Now let's go with ACE inhibitors. Blocks the conversion of angiotensin 1 to 2 by interfering with the ACE enzyme in the lungs. Arterial dilation, causing lowered peripheral vascular resistance. And it also inhibits kinase 2, which is a vasodilator, or it causes vasodilation, but that's why bradykinin can't get broke down, which causes the cough. Side effects: angioedema, hyperkalemia, and worsening renal function. Contraindications: preggers and angioedema. Now let's go to ARBs. Mechanism of action: antagonizes, so blocks angiotensin 2 at the angiotensin 2 receptor, or the AT receptor, reducing systemic vascular resistance. Side effects: angioedema, hyperkalemia, worsening renal function. Contraindications: pregnancy. Now let's go with non-DHP calcium channel blockers and DHP calcium channel blockers. They both inhibit the influx of calcium across myocardial and vascular smooth cells, decreases intracellular calcium, and inhibits contractile process of muscle cells, causing dilation. Side effects of non-DHP calcium channel blockers: bradycardia, constipation, so this is verapamil and diltiazem, gingival hypoplasia, and worsening heart failure. Shit ton of contraindications: acute MI, AV block, cardiogenic shock, heart failure, Long-Ganong-Levine syndrome, sick sinus syndrome, VTAC, and Wolff-Parkinson syndrome. So side effects of DHP calcium channel blockers: so amlodipine, all the penes, peripheral edema, and headache and flushing. Now let's go to alpha-1 blockers. I just spilled my drink. Alpha-1 blockers, so mechanisms of action: they cause peripheral vasodilation, decreasing peripheral vascular resistance. Side effects: sexual dysfunction, nasal stuffiness, and postural hypotension. Now, central alpha-2 agonists, so this is like clonidine, I believe, and like dexmedetomidine. Inhibits sympathetic outflow and tone, decreases vascular tone in the heart, kidneys, and peripheral vasculature, lowering peripheral vascular resistance. Side effects: bradycardia, dry mouth, orthostatic hypotension, rebound hypertension, and rash if you have the clonidine patch. Now we're on to the last one: direct vasodilators. Mechanisms of action: vasodilation. Orthostatic hypotension, reflex tachycardia, rebound sodium retention, and hydralazine can cause lupus, and minoxidil can cause hirsutism, which is like facial hair. Contraindications: chromocytoma for minoxidil, and CAD and rheumatic heart disease in hydralazine. So we're almost done. Special populations, ACE and ARB for diabetics, ACE and ARB plus a diuretic for CKD, heart failure, ACE or an ARB and a beta blocker, ischemic heart disease, beta blocker. So let's go over that again. Diabetes, ACE or an ARB. CKD, ACE or an ARB plus a diuretic. Heart failure, ACE or an ARB plus a beta blocker. Ischemic heart disease, beta blocker. So if you have CVD or cerebral vascular disease, if you have acute stroke, you want the blood pressure to be less than 220 over 120 over 40. And if it's not, you want to lower it by 10 to 15%. A little tidbit about resistant hypertension. It's if you've been on 3 meds, including a diuretic. That's about all I have for that. Hypertension emergency, that is if your blood pressure is greater than 180 over 120 and you have signs of organ dysfunction, which would be encephalopathy, ICH or an intracerebral hemorrhage, a stroke, aka a stroke, an MI, acute left ventricular failure with pulmonary edema, angina, dissecting aortic aneurysm, or eclampsia. So what do? Reduce the blood pressure by 25% in the first hour, then to 160 over 100 to 110 over the next 2 to 6 hours, and you should have a normal blood pressure in 24 to 48 hours. And that is an emergency. So the difference between an emergency and urgency is the fact that there's organ dysfunction. So urgency, you should be like, the urgency is there, but emergency, it's there already. So urgency, you use PO meds. Emergency, use IV. So urgency, use captopril, labetalol, and clonidine. Also, another tidbit, if you're pregnant, use labetalol or methyldopa. I always remember labetalol, like lababilol, baby, use it with the baby. But that is hypertension. I will catch you on the flip side.